You can spend 3 nights in a hospital bed, in a hospital gown, treated by hospital doctors, and still be told on paper that you were never actually admitted. One word decides it: observation. And that one word can cost you $20,000. Here is how to catch it before you ever leave that hospital. Ruth is 71 years old. On a Monday morning in October, she checks into the cardiac floor of her regional hospital with chest pain and shortness of breath. The nurses are attentive. The tests are thorough. She spends Monday night, Tuesday night, and Wednesday night in a room on the 4th floor, monitored, medicated, cared for. Thursday morning, the doctor tells her the cardiac event was minor. She is stable, and she can be discharged to a skilled nursing facility for recovery. Ruth is relieved. She has Medicare. She has been in the hospital for 3 days. She assumes she is covered. The bill arrives 6 weeks later, $19,400 in patient cost sharing. Ruth was never admitted. On every form that mattered, she was classified as an outpatient under observation status. 3 nights in a hospital bed, 0 qualifying inpatient days, and a bill that will take her 2 years to negotiate down to something she can survive financially. This is not a rare edge case. This is a documented systemic feature of how Medicare billing works, and the gap between what patients believe is happening and what is actually being recorded is where $20,000 disappears. Here is the mechanism. Picture 2 patients, same hospital, same floor, same diagnosis. Their rooms are separated by 40 feet of corridor. Patient 1 has been formally admitted as an inpatient. A physician wrote the order. It is in the chart. Medicare Part A is active. Patient 1 pays the 2024 Part A deductible, $1,632. That is the ceiling for the first 60 days. Patient 2 in the room down the hall is under observation status. She is classified as an outpatient, receiving extended observation services. Medicare Part B applies. Part B covers 80% of approved outpatient charges, which means the patient owes 20% coinsurance on every individual service. Every imaging study, every IV medication, every specialist consultation, each one billed separately, each one generating its own 20% exposure. It compounds fast. A 3-night observation stay with cardiac monitoring, echocardiograms, blood draws, and a handful of specialist visits can generate an itemized bill where the patient's share reaches $15,000 to $20,000 before the skilled nursing question even enters the picture. And there is a second trap buried inside the first one. Drugs administered during an observation stay are frequently not covered under Part B at all. The hospital pharmacy dispenses them, but Part B does not cover most self-administered drugs in an outpatient setting. The patient is directed to bill their Part D drug plan, which may not cover hospital-administered medications, leaving them paying retail price for drugs they received while lying in a hospital bed. The Medicare Payment Advisory Commission has tracked a sharp increase in observation stays of 3 or more nights over the past decade. The reason is not clinical, it is financial. Medicare's recovery audit, contractors, the RACS, audit inpatient admissions aggressively and can demand repayment if they determine admission criteria were not met. Hospitals have learned that classifying borderline cases as observation reduces their audit exposure. The financial risk shifts from the hospital to the patient, quietly, completely. Now comes the second consequence, and for many families, it is the larger one. Medicare's skilled nursing facility benefit has a hard prerequisite: a prior inpatient hospital stay of at least 3 consecutive days. This is called the 3-day rule. Observation days do not count toward those 3 days. They never have. Ruth spent 3 nights in the hospital, but her inpatient day count is 0. When she is discharged to the skilled nursing facility for post-cardiac rehabilitation, Medicare covers nothing. Not day 1, not day 30. Skilled nursing care averages $300 to $500 per day. A 30-day stay runs $9,000 to $15,000 out of pocket. Stack that on top of the observation period cost sharing, and the total financial exposure for a single hospitalization reaches $20,000 to $35,000 from a stay the patient experienced as completely normal, completely covered, completely taken care of, Congress passed the Notice Act in 2016. It requires hospitals to provide written notification, the Medicare Outpatient Observation Notice, the MOON form, to any patient who has been under observation status for more than 24 hours. The notice must be delivered within 36 hours. It exists. It is a real protection. But there is a difference between delivering a form and explaining what it means at 11 o'clock at night when someone's mother is in pain and the hallway is quiet and a staff member hands over a clipboard and says she just needs a signature. Ruth's daughter signed the MOON form that night. She did not know it was the document that would strip her mother's skilled nursing eligibility. No one offered to explain it. The form was delivered. The requirement was met. The damage was done. Which brings us to the only intervention that actually works, and it has to happen before you leave that hospital. The single most powerful question a Medicare patient or their family can ask is this: am I admitted as an inpatient, or am I under observation status? Ask it in writing. Ask it within the first 24 hours. Ask it of the attending physician, not the nurse, not the billing desk, not the case manager. The attending physician is the one with the clinical authority to write an inpatient admission order or to review whether the current classification meets inpatient criteria. The exact language matters. Say, I am requesting clarification of my admission status for Medicare purposes, and I am asking you to review whether an inpatient admission order is clinically appropriate. That phrasing signals that you understand the system. It creates a documented request, and it puts the decision back in front of the person who can actually change it. Physicians have genuine discretion here. The classification is not automatic, and it is not irreversible in the first 24 hours. But hospitals operate under real RAC audit pressure, and some physicians will default to observation for borderline cases because that is what the compliance culture has trained them to do. If the physician pushes back, you have the right to ask for the hospital's patient advocate or its Medicare compliance officer. That escalation exists. Most patients never know to use it. If Ruth's daughter had asked that question Monday evening, the night of admission, then the attending could have reviewed the interqual or Milliman clinical criteria and potentially written an inpatient order. She did not know to ask. The window closed. By Tuesday morning, the billing classification was embedded in the system. What happens if you are already home when you find out? There are two formal pathways, and neither is easy. The first is appealing the observation classification itself. File a written appeal with the hospital's Patient Financial Services Department, citing the clinical record and arguing that inpatient admission criteria were met. If the hospital denies the appeal, escalate to the Beneficiary and Family-Centered Care Quality Improvement Organization, the BFCC-QIO, assigned to your state. The QIO has the authority to review whether inpatient criteria were satisfied and to reverse the classification retroactively. This is a formal process with deadlines. The strongest position is to request QIO review before discharge or within days of receiving the MOON notice. Post-discharge, the window narrows significantly. The second pathway is appealing the resulting SNF denial directly. File a formal Medicare redetermination with the Medicare administrative contractor. Document the clinical record. Argue the admission criteria. Success rates are not high, but reversals happen, and the Center for Medicare Advocacy, which has litigated observation status cases for more than a decade, maintains free resources that walk patients through the process step by step. The hard truth is that the system is designed so that most people give up. The appeals are slow, the language is technical, and the deadlines are unforgiving. Ruth filed a QIO appeal. It took 4 months. The classification was not reversed, but she hired an advocate, documented her financial hardship, and negotiated the skilled nursing bill down by 40% through the facility's own assistance program. A partial win, not justice, not what she was owed, but 40% of a $15,000 bill is real money, and she got it because she did not stop asking. Think about where we started. A hospital bed, a hospital gown, doctors making rounds, nurses checking monitors, an IV in your arm. Every physical signal your senses can register says, you are a patient. You are admitted, you are covered. None of that is true unless one specific order exists in your chart. Not the bed, not the gown, not the attending physician's presence. A single line of documentation, inpatient admission order, is the only thing that activates Medicare Part A. Without it, you are an outpatient who happens to be sleeping in a hospital. The word observation on a form you may never see unless you ask is making a $20,000 decision on your behalf. That is the reframe. Hold it. Because here is what changes when you hold it. You stop waiting for the system to protect you, and you start asking the one question that actually does. There is a wallet card linked below this video. 3 lines. Print it. Fold it. Put it behind your insurance card right now, before anyone you love needs a hospital. Line 1. Ask within 24 hours. Am I admitted as inpatient or am I under observation status? Line 2. If the answer is observation, I am requesting physician review of whether inpatient admission criteria are met. Line 3. If you are discharged under observation, contact your state's BFC QIO within days, not weeks. Days. That is the entire intervention. 3 questions. 1 card. The window is narrow, the language is specific, and almost nobody tells you this until the bill arrives. I spent 28 years inside a major carrier and its Medicare Advantage operation. Of every billing trap I watched play out, and there were many, observation status is the most consistent, the most preventable, and the most deliberately obscure. The system is not broken. It functions exactly as designed. The only variable it cannot account for is a patient who already knows the question. This channel is not affiliated with any insurer, any government agency, or CMS. Nothing here is legal or medical advice. It exists because someone has to say it plainly. Now you know.